So good evening all. Welcome everyone to the PG case presentation series conducted by IRIA Kerala in association with Genomed. And for this, I welcome Dr. Gomadi Subramaniam, President Kerala IRIA, Dr. Rijo Matthew, Secretary Kerala IRIA, and Dr. Ramesh and I, Program Coordinator. And today actually we are going to discuss interventional radiology based some cases. And this is being moderated by Dr. Avani KPS Kandan, Consultant Radiologist, Aster MIMS, Calicut. Welcome, Dr. Avani. And our faculty is Dr. Harish K, Assistant Professor, Neuro and Vascular Interventional Radiology, SJMCH, Bangalore. Happy welcome, Dr. Harshit. And now over to Dr. Avani for the introduction of our faculty.
Thank you so much, sir. Good evening, everybody, and welcome to our session, like sir said. And already sir has mentioned about our faculty today. He has been a speaker with us earlier too in Kerala IRIA academic sessions. And he is one of those rare people in radiology. We have very limited number of interventional radiologists. Definitely it's an upcoming subspecialty in our radiology, but there's a limited number of them and very limited number of them who are actively involved in academics. We are lucky that Dr. Harshit happens to be an academician also, along with being an interventional radiologist. And like sir mentioned, he is an assistant professor and consultant, neuro and vascular interventional radiology at St. John's Medical College Hospital, Bangalore. And he is a very, because we have attended his classes earlier too, we know he's a very good academician. He has brought along with him today with for the discussion, we have his PG, third year PG, Dr. Shreyas ready for the session. And we all have very limited exposure with interventional cases. So I'm sure this is going to be ultimately very, very useful for the students because we see less number of cases, less number of instruments. And he has tried to maximize the effect by putting a lot of cases, making it more case-based and more useful for the PG approach. So hopefully everybody will find it very useful. So over to you, Dr. Harshit and Dr. Shreyas.
Thank you, ma'am. Good evening, everyone. Thank you, Kerala IRA, for this opportunity so that we can spread the awareness about interventional radiology, which often is not that much given importance. Off lately, it is being given a lot of importance during the PGS itself. But when I was a PG, it was not much of exposure. But it is good that IRA is conducting these type of conferences so that we can inculcate the habit and exposure to intervention radiology. And there are people, a lot of people, PG, especially PGs, second year, third year, and all who are interested in doing interventions and want to venture into this field. So we go directly into the presentation. I will not waste much time and because I want to show more cases. I have with me Dr. Shreyas, who is our PG in final year. He's very enthusiastic about interventions and all. He does also a lot of cases and all with us. So he's the right person, so I've got the right person with me. Again, this will be more of teaching session. I'll not go too deep into all the cases. It will be just an introduction of what is to be expected of every case. Like if you get a even a simple case of cavity in the lung, it can turn into an intervention and can go into that. So what is this? What is the scenario currently, and what are the intervention cases that can be asked? It will be the basics actually. I will not go too deep into that stuff. And it will also be helpful for the people who are final year PGs who want to venture into intervention in the future when they are giving interviews and all or writing exams in the future for most of the institutes. These similar questions can be asked in the future. So it will be in so that they can tailor their reading and their academic thing in a manner. So we'll try to help. We'll try to push in as much content as possible in a short period of time. So we'll now start the case presentation. Over to Dr. Shreyas. So without much of detail, we'll directly go into the cases for today. You can take over, Dr. Shreyas.
Good evening, everybody. So we will be starting the case-based review today. So myself, I'm Dr. Shreyas, and the examiner, my assistant professor, Dr. Harshit. So this is the first case. So this is a 68-year-old male who presented with chest pain and breathlessness, and he presented to chest medicine OPD. An X-ray was done. So this X-ray shows a homogeneous opacity in the right lower zone. As you can see, its medial border is silhouetted with that of the right heart cord border. Apart from that, you can also see some inhomogeneous opacities in bilateral lower zone.
What is your most common differential? How do you say where this mass is located, Dr. Shreyas?
Since it is silhouetting the right heart border, I would assume that this mass to be somewhere related to the middle mediastinum.
Okay.
So to further delineate its anatomical characterization, I would like to do a CT.
Okay, what is the plausible diagnosis that you are keeping in mind when you, because this can come as an exam question for you. What is the plausible diagnosis that you are keeping in your mind?
First, I would think of as a lung neoplasm.
That is the most common thing that comes in the area. That's the right heart. Chamber dilatation needs to be kept in mind, and the pericardial cyst is what is to be kept in mind. And of course, a lung neoplasm is possible because, okay, we'll proceed. We'll not go much into this here because this is not a session on this. Okay, you have a picture of a middle mediastinal mass now currently given to you. So how will you proceed next?
I would like to do a contrast enhanced CT of the chest.
Yes. Okay, that was the mass which is silhouetting the right heart border over there. Can we proceed with the CT now? Just briefly, this will be if we go into the like cine views and it will be too much. So I'm just putting the spotters here so that it can be easier for the discussion and we can go into the questions directly. Can you interpret the chest X-ray, Dr. Sheth?
So this is a contrast enhanced CT of the chest in the mediastinal window, which is showing a heterogeneously enhancing mass, which is showing loss of fat planes of the right heart border. It's broad-based towards the mediastinal.
Fat planes are maintained here. I would not comment on the flat planes or not because this is a thicker cuts. You need a far thinner cuts to comment whether there is an infiltration of the heart border. So this is a mass which is located in the middle mediastinum. What do you think is the origin? Where is the origin? Subpleural, pulmonary. What do you think?
Intrapulmonary.
How do you say that it's an intrapulmonary mass? It's an extrapleural because at obtuse angles it is making with the pleura. So it's a obtuse angle which is forming with the basically the pleural border. So it is most probably it's a mediastinal mass, subpleural lesion. So now to make a diagnosis, so many possibilities are possible with this one. So you are asked to do a chest biopsy for this one. How will you proceed with the patient? Now a request comes to you when you are sitting in OPD, in the radiology OPD, and a request comes that okay, we do not know the characteristics of the mass. So how will you proceed with the biopsy of this patient? So that is the core of this case. We want to proceed with how a biopsy is undertaken for a patient from the first time you see it. You can proceed.
First, I would like to review the images that have been provided and plan the approach as to how we can target its lesion. And also, we must also look at whether the lesion is central or peripheral, because central lesions are more amenable to bronchoscopic biopsies, whereas peripheral, we can do intervention, can take up and do biopsy. So since this lesion is more anterior, I would like to do a anterior approach to reach this lesion.
And before you go in for approaches, what are the other things that you see when you are doing a biopsy? Like a patient comes to your OPD. So what is the first thing that you will notice? You will ask for the history of the patient. And what is the other thing that you will look very important thing when you take up for any intervention per se? What are the other things that you do?
Blood investigations. If anything is abnormal, we will keep an eye out for it.
Most important thing, blood investigation that you will look up in this patient before doing a biopsy?
PT.
Exactly, PT, INR, and platelet. These are the coagulation parameters you should always keep in mind, anybody for that matter, before you take up the patient for any non-vascular or vascular intervention. Fine. Now the patient has come to you, you have looked up the INR, PT, INR, all is normal. Now how will you proceed with the biopsy of this patient? Let's show the next film when we have done the biopsy. So how will you proceed and do the biopsy? What is the technique used for doing the biopsy?
So we would like to do this biopsy under CT guidance. First, we'll place the radio opaque grid and localize the appropriate entry point, following which we will sterilize the region and infiltrate the local anesthesia. So we will be using the coaxial technique to obtain multiple samples from this lesion.
Yeah. This is what I wanted to get out from your thing. We will use a coaxial technique. So can you just briefly explain to us what is the coaxial technique that is used for this case, Dr. Sher?
So coaxial Coaxial technique basically in simple terms means we will leave the trocar needle within the lesion, and we will be taking the biopsy multiple times. So this prevents us from entering the lung multiple times, thereby reducing the chances of pneumothorax.
Exactly, very good. So we use a coaxial technique. We will place a coaxial needle first, that is the access needle into the lesion. So, and through that coaxial system, we like to put in the biopsy gun so that we prevent the traversing of the pleura and the lung parenchyma multiple times, which is the most common cause of pneumothorax in most of the cases. And why we have chosen the CT approach for this case, Dr. Shreyas?
Because there is intervening lung tissue which is lies between the subcutaneous skin as well as the mass. So that is we cannot visualize that on ultrasound guidance. Therefore, CT is preferred here.
Exactly. So the lung parenchyma generally forms as a barrier between the visualization of soft tissue masses. So we have gone and taken the lung CT approach. Okay. So can you just name a few biopsy guns that you commonly use in your practice?
So biopsy guns broadly can be divided into semi-automated and automated guns.
Yeah.
So these are the two types. The first image is that of a semi-automated gun, and the second one is that of an automated gun.
Generally, in the exams, we keep this as specimens on the table so that the resident can pick up and show us what exactly is the gun that has been provided. What is the specialty of this semi-automatic gun? Can you tell me one specialty of the semi-automatic gun that was not there with the automatic gun? The length of the core of the sample, that you can see a marker over here, that sample length can be adjusted on the semi-automatic gun, but it can't be done so on the automatic gun. But of course, there are other guns where you can set the sample length also. That is possible. But this is the main difference, and that's what we are using. So, okay, now you have taken the biopsy course actually, and what are the complications that you might face in this patient after doing the biopsy?
So the most common complication that occurs after a lung biopsy is pneumothorax. The lesser known complications include hemorrhage, hemothorax, and injury to any important vascular structure close by to the lesion.
Okay. So now suppose you are doing this biopsy and inadvertently injured the lung and patient now has a pneumothorax. Pneumothorax. How will you go about caring for the patient? On table you have done a CT, you see a pneumothorax. What will you do?
So the next intervention depends on the size of the pneumothorax. If it is a small pneumothorax, we can actually aspirate it while we are removing the needle itself.
Small pneumothorax, you do not aspirate. Small pneumothorax, you observe for 6 hours. Yeah, you can proceed. Moderate pneumothorax?
Moderate pneumothorax, we can aspirate the air when we are removing the biopsy needle itself. During coaxial, when we are removing the coaxial needle itself.
Yes. And large pneumothorax?
If it is a larger pneumothorax, we would place an ICD tube along with the water seal technique.
Yeah. So the larger pneumothorax only if it causes discomfort to the patient, say sputum drop, the patient is not able to breathe properly. So that is one thing. What if now say the patient is coughing out blood on the table when you have done the post biopsy? So what will you do in such cases?
So if patient is having hemoptysis, so what we will do is we will position the patient in the decubitus, left lateral decubitus position, and we should place it on the side where the biopsy is performed.
Yes.
So for example, if you performed a left lung biopsy, if patient is having hemoptysis, we will put him in left lateral decubitus position. This is to prevent aspiration of the blood contents into the contralateral.
Yeah, so that the blood which is bleeding just stays on the affected lung itself and doesn't go into the normal lung parenchyma and prevents the patient, drops the patient saturation. Fine. So there is one precaution that you take while removing the needle. I think I've told multiple times in we are performing a biopsy. So what is the most common technique that you use to prevent a pneumothorax in one patient? So, like sometimes even the puncture lesion that you've taken in the lung can also lead on to pneumothorax. What precaution do you take generally to prevent that to happen?
We usually should never put the biopsy needle with the tip facing upwards.
No. There is something called a tincture seal technique, where you seal the skin with a cotton swab and put tincture on that, and you seal the skin entrance so that the path which is created by the lung biopsy is sealed up, so that there is no entry of air inside. Also, but entry of air to the lung entry, like chest wall entry site, is very rare. So, but especially if the patient has pneumothorax, we can actually go and seal that Okay, I think this much is enough. Can you just name some other biopsy guns that you are aware of?
Apart from the routine biopsy guns for soft tissues, we have bone biopsy guns.
Yes.
So the two most common ones we use are the Jamshedi one, which is displayed in the first image, and the second one is the Ackerman type of bone biopsy gun.
Or which what is the company that you're using very often? This is called osteocyte, Cook's osteocyte. So these two samples will be generally kept as a spotter, or can be kept in the discussion also. So the PG will be asked to pick it up and tell what is this role of this special instrument. So this is a bone biopsy gun, as Dr. Shreyas has already told. So I think the biopsy part is still basics. I think everybody does biopsies routinely, and so ultrasound guided biopsies is very often done. So I'm not put in much. So we'll go on to, as we proceed now, we'll go on to a little more complicated stuff. Okay, can we go to the next case? Can you present the next case?
So this is a 27-year-old male, known case of known alcohol and as well as a smoker. He presented to the emergency with severe pain abdomen. Serum amylase levels were elevated, counts were elevated, and USG done which was suggestive of a possible pancreatitis. Patient deteriorated and consequently a CT was performed.
Okay, wait a second. So now we already know the diagnosis of possible pancreatitis. It is said in literature that you do not do further imaging for all the cases of pancreatitis. When will you image a patient with pancreatitis? Say a CT scan or now it is routinely done for most of the patients, but what are the indications to do a CT in a case of suspected pancreatitis?
One would be vascular complications, to look for any vascular complications.
Go from the basic ones. The basic ones like cirrhosis formation, acute fluid collection. If the patient pancreatitis is severe, to look for the status of necrosis, and the associated complications like vascular complications, biliary complications. So that is where you go and do a further imaging. That is what is the imaging performed?
Contrast enhanced.
What is it called? It's a dual phase.
Dual phase.
Yeah, dual phase. So be very specific of what you are telling. So it's a pancreatic protocol or a dual phase. Can you go ahead, please see the images and describe the images?
So the first image that is provided is an axial section at the level of the pancreas. It is a venous phase image, and that is showing a large collection that is replacing the pancreatic body as well as the tail. There are severe peripancreatic inflammatory changes and some ill-defined fluid.
What is the other thing that you're noticing in the same image?
There is a small air foci within the collection.
What does that mean?
That is possible infected collection.
It's an abscess forming. That is why the patient has deteriorated. So if, for example, say this patient has deteriorated and the HB is dropping, what else will you look for in this image?
Maybe possible vascular complication or formation of a pseudoaneurysm.
Yes. Which artery is the one that most commonly gets affected in cases of pancreatitis?
Most commonly, it will be the gastroduodenal artery.
Yes.
Sometimes even the splenic artery can also be involved.
Excellent. So these are the two arteries, and these are the areas where you actually look for coactive contrast extravasation. Okay. So Shreyas, coming on to some other things, what do you see? There is some other thing also which is seen in this CT image. What is that? There is some inflammatory changes around the pancreatic region. So what is there? And there is mesenteric elemental inflammation also noted in there. So that be specific when you're telling. Okay. So in this image, if an image like this is given to you, what is one very important thing that you look for in this image? That is, you look for the duct disruption. If there is any communication with the duct, if there are any stones in the duct, and if there is any stenosis in the duct. So generally, you cannot make out most of the times, but if you can see it, just see it and tell the gastroenterologist. Okay, then what has been performed for this patient?
Here we have performed a pigtail catheter placement within the infected collection.
Yes.
Under CT guidance.
Yes. Why do you choose CT guidance for this patient?
As you can see that very close colonic bowel loop is just superior to this patient. So under ultrasound, that would be interspersed between our area of interest. Yes. So therefore, CT is better.
Yes, it's a retroperitoneal collection, which is closer to the air in the bowel, and so might be difficult for us to visualize by ultrasound. So we have chosen a CT part. Okay, so you have put in a pigtail for this patient drainage. So what are the types of drainage catheter you know of that you are using in your routine practice?
So routinely we can use two types of catheters. One is the routine pigtail catheter, and another one is the Malacot catheter.
So these two are spotters which are generally again kept in the exams. One is a pigtail catheter. So this is the marker. So we can go ahead and show the what is this catheter you just told now?
So here these two images show the Malacot catheter.
Yes. This is a different patient where you have kept a Malacot catheter. So this is a spotter image again. Can you identify these two catheters, Dr. Shreya?
The first image is that of a routine pigtail catheter. The second one is that of a Malacot catheter.
Now, what is special in this? We know of the routine pigtail catheters that you are using in your day-to-day practice. What is special about this pigtail catheter? In this image, what do you see there? There is a thread coming out. So what is it?
We
called?
can
locking pigtail.
locking pigtail.
Locking type of pigtail, because most of the patients, when you place a normal pigtail, they generally tend to pull it out. So these are the special pigtails wherein you can lock it inside. You can pull the thread and lock it pigtail inside. Okay. So what is the benefit of putting in a Malacot's catheter in a patient? Say, what is the benefit of putting Malacot's over a pigtail catheter? So the Malacot catheter apparently has wider holes, and the entire catheter movement, the 16 or 17, 18 friends that you're putting, the entire utilized for draining the abscess. While in a pigtail, it is just the smaller side nodes which are not entirely the size as huge as a Malacot catheter. So Malacot catheter is generally better, and nowadays better hydrophilic catheters are also come, so that it makes our job easier. So can you describe the techniques of insertion of a pigtail? What are the two techniques that you are now aware of?
So there are mainly two techniques. One will be the direct trocar method, and the other one is the Seldinger technique.
Yeah, can you describe Seldinger technique to me?
So Seldinger technique, we will be using a guide wire over which we will be passing the catheter.
First puncture with a needle and aspirate the contents. Confirm that you are inside the abscess. Okay. Then
through the needle, we will be passing the guide wire into the collection.
Yes.
And we'll secure the guide wire and remove the needle, over which we will pass the
multiple dilators.
Multiple dilators.
We dilate the tract,
and following which we will place the pigtail.
Seldinger technique is supposed to be safer than trocar technique because it's very controlled insertion of pigtail. So most of our practice generally is a Seldinger technique. Okay. So now that we have covered an abscess drainage part, again ultrasound guided abscess and CT guided abscesses are the same. The hardware is the same. So the crux of this case was to highlight the case of pancreatitis, when to intervene, when not to intervene. Again, Dr. Shreyas, I'd like to ask you one more question. So how long will you wait? Say a patient comes with a pancreatitis and has a large fluid collection in the abdomen. So will you go and intervene, or what will you do?
Ideally, we will have to wait for 4 weeks.
Yes.
For the formation of either a pseudocyst or the acute wall of necrosis. Yes. Only which after which we are supposed to intervene.
So acute fluid collection, generally they say that it's a sterile fluid collection, which is generally consisting of the pancreatic fluid. So need not go and intervene immediately. It generally gets absorbed by itself. If it persists and forms a pseudocyst, after 4 to 6 weeks, we generally go and intervene. But again, what is the most best treatment modality for a case of necrotizing pancreatitis?
It will always be necrosectomy.
Yes, surgery. So do not go and intervene in such cases. It is always surgery. But if you want to bridge or get some time before surgery is done, we can actually any day insert a Malacot catheter. That is a large bore 16 or 18 French Malacot. Okay. So this part covers the drainage part. Can we go on to the next case, please?
This is a 68-year-old male. He was admitted in the ICU with respiratory tract infection.
This was a COVID patient.
COVID patient, secondary developed sepsis. Yes. His counts were elevated, and bedside ultrasound was done, which showed a distended gallbladder.
And also, patient was complaining of pain in the right upper quadrant. Okay.
Consequently, a CT abdomen was.
So, with this history, what comes into your mind first? Right hypochondriac pain, sepsis, a bedridden ICU patient on total parenteral nutrition, and you are showing a distended gallbladder. What will you think?
So I will be first thinking of a possibility of acalculous cholecystitis.
No, just cholecystitis. We do not know. You have done an ultrasound. It shows a distended GB. So calculus acalculus is later. So it features a suggestion of
cholecystitis.
Cholecystitis, yes. So then you go on and look for stones and all that. And then you say whether it's a calculus and acalculus. So okay, so CT abdominal. So can you review the CT images, please? What does it show?
So this is a contrast enhanced CT section of the gallbladder in the
No,
artery
it's abdomen.
and of the abdomen. So it is showing a overly distended gallbladder with thickened gallbladder wall with a significant pericholecystic fluid and fat stenting.
Yes. So the suggestive
And there are no calculi seen. So this is an case of acalculous cholecystitis.
acalculous cholecystitis, which is very common in cases of patients who are total peritoneal or ICU patients who are peritoneal. Fine. Now the surgeon comes and tells you that patient is not fit for surgery, or the INR is deranged, or the electrolytes are deranged, and he asks you to intervene. What is the procedure that you will perform?
So since the patient is not amenable for surgery, we can perform a percutaneous cholecystostomy.
Yes.
So this can be done under ultrasound guidance.
Yes. So it is done under ultrasound guidance, but in cases of say gangrenous where there is air and all inside and abscess, you need CT guidance. Yes. So can you just tell me what are the techniques or what are the routes of performing a percutaneous cholecystostomy?
There are two routes which you can use to perform this procedure. One will be the transhepatic route. The other will be a transperitoneal route.
Yeah, when and where will you use each technique?
So transhepatic route will give us good leverage of the pigtail catheter, but the bleeding complications will be more with the transhepatic route.
Yes.
But the chances of peritonitis occurring will be lesser.
Yes.
Whereas in transperitoneal route, the bleeding chances will be less, but the chances of peritonitis will be more.
And catheter slippage.
Catheter slippage will be more.
So what special catheter do you use for performing the percutaneous cholecystostomy? I just told you what is the catheter, pigtail catheter. Locking pigtail. Always use a locking pigtail for performing a percutaneous cholecystostomy, because these patients are ICU bed bound. They might be disoriented. They might pull out the catheter also. These catheters hold it in place. So can you read the last image? What has been performed there?
So this is an X-ray that is taken after taken after the procedure. Here you can see the curled catheter, which is the blocking pigtail that we have used to treat this patient.
And how will you do the procedure? What is the technique you will use? It's again ascending. It's always ascending technique. It's very safe and easier to perform than a trocar technique. Okay, so ascending technique is used. So what are the complications of percutaneous cholecystostomy?
One would be injury to the adjacent structures, adjacent bowel loops as well as the vascular structures. Second one would that be of biliary peritonitis.
Yes. Biliary peritonitis, injury to liver, and bleeding complications. Now, say the surgeon says that I do not want to operate on these patients after 6 weeks. That is the interval time. So, what extra thing can, as an interventional radiologist, can you perform on this patient so as to cure his condition? Now you want to cure his so that cholecystitis doesn't happen. So an option is to do cholecystectomy, which a surgeon denies and says that I do not want to do it. What will you help him with?
You can perform a T-tube.
No. It's a stereoshunt injection into the gallbladder through the pigtail. And what is the fluorescing agent that is used? It's absolute alcohol. Okay, so you can inject absolute alcohol into the gallbladder. It causes sclerosis of the gallbladder wall and it tends to shrink on itself. Okay, so over that, slowly you can remove the pigtail also once the gallbladder is completely gone. Okay, so this was just to show where all pigtails can be used and drainage can be done. So we'll switch on to the next case actually, which actual intervention starts from here. This is just a companion case to show the percutaneous cholecystostomy. This is what he just told, the transhepatic and transperitoneal. Okay, I think Shreyas has already told. Can you go on to the next case, Shreyas?
So this is a 57-year-old male came with pain abdomen and jaundice. Ultrasound showed IHPRD and no ascites. Total bilirubin was of 18 milligram per deciliter. LFT is mildly abnormal and MRI was done at the outset center. Luckily, we had the chance to review the MRI. So this is an MRCP, 3D MRCP image, which is showing the grossly dilated ductal system, both on the right as well as the left side. And there is an evidence of an ill-defined mass at the hilum. So at our center, we consequently performed.
What is there? More you have to. What do you see in the MRCP? How do you review an MRCP image? What is the? Can you tell me there is something peculiar about this case? What do you see in the MRCP, that picture-heavy-weighted image? What do you see there? You see the isolation of the sex. What is isolation? Isolation is when all the ducts are segregated because of the mass. They are separated. There is no joining place. It's a so. What is the probable diagnosis that you will consider in this patient?
So since the all the ducts are isolated, that means there is a mass infiltrating the confluence.
What is it called?
It's a hilar cholangitis.
What is it called otherwise?
Klatskin's tumor.
Yes, Klatskin tumor. So what is the classification system that is used?
Bismuth cholera.
Yeah, what type would you put that in this case into?
This will be type 1.
How will it be type 1? What is the types of bismuth colored classification?
Type 1 will be involving only the confluence.
No, it is far away from the confluence.
Yeah, type 1 is, yeah.
This would go into type 3 at least, type 3 or type 4, okay? So when either there is a more involvement of the right side or the left, okay? So bismuth colored classification needs to be studied in detail, okay? So this is when you see a patient like this, because based on the bismuth classification, our approach to this patient changes, okay? So I'll just tell you about, can you just see the CT image? CT image was just done to see if there are any other metastases and CT. So now this is an inoperable image. Inoperable stage of the malignancy. This is a hilar cholangiocarcinoma. So now the surgeon or the oncologist, what would be the biliary system is dilated. So now what will be the first option in this case to drain the biliary system?
So we have two options at our disposal. One would be of a PTBD, the other would be of an ERCP. So ERCP we can consider if the level of the obstruction is either at the lower at the mid level. Since in this case, which segment? Since in our case it is much higher up. It's at the level of the confluence and involving the both the right and left hepatic ducts. We will consider PTBD to be the better option.
Excellent, excellent. So PTBD is generally considered in patients, so they're very high up, like in the confluence lesions and all, or when the ERCP has failed. Okay, so that is when people do attempt ERCP in these cases, but generally it fails because of the very high level of the lesion. Can you go to the next case, next slide? So what is performed here? Can you just explain the procedure?
So here first we're doing performing a cholangiogram under the fluoroscopic image.
Yes.
It's showing a cholangiogram using the axis on the left side of the left-sided axis. So we have performed a sheath cholangiogram, which is showing multiple dilated ducts.
And what you are not seeing here, so you are seeing only partially. You are seeing segment 3, 2, and 4 ducts only. So the right side is entirely visible. So what does that mean?
So that means the both ducts isolated ducts.
Yes, you have seen on MRCP already. So that's our isolated. So this is how MRCP gives us a picture of what to do next. So what is performed here next? Can you just describe what is procedure performed in the next slide? So next image.
So what we have done is PTBD, or percutaneous transhepatic biliary drainage.
Yeah.
So what we have done is after securing access into the duct, we have passed the guide wire to navigate the area of obstruction, over which we have passed the catheter distal to the level of the obstruction.
Yes. Can you describe me the stages of doing a PTBD, which is ideally needs to be supposed to be there?
So ideally, PTBD is performed in 3 stages.
Yes.
First, we would externalize the biliary drainage output, following which we will be doing a internal drainage, and finally a stenting procedure.
Internal and external.
Internal and external, and finally a
total internal drainage.
Total.
So why do you think we should do a external drainage first and not directly go for an internal drainage? This is just an out of box project. This will not be asked in exam, just for curiosity's sake for yours. Why do you generally do not internalize in the very first attempt? The mass generally bile is a very caustic agent, so generally causes inflammation of the tumor. Okay, so you are not supposed to, because bleeding risk will be very, very high when you directly go and internalize. Of course, we have done for a few cases, nothing has happened. So this is an internal external drainage. Okay, so what will be the next step in this case?
We will be performing a stenting.
Why? What is stenting? It's a total internal
drainage.
That's why would you perform a stenting in this case, and why not leave the picture catheter there draining?
Patient can lose electrolytes if we leave the
important bile
salts. If we leave the picture to be externalized. Therefore, we will want to restore the normal physiology as soon as possible. Therefore, we will choose for stenting.
Can you show the next image? What is being performed to this patient? Let's go next slide. What is performed here?
So we have placed a self-expanding metallic stent across the level of the lesion
into the duodenum.
Into the duodenum.
Excellent. So now that stenting is performed, So this patient, what will you do with the pigtail catheter? Will you keep it there or will you remove it? Have your internal lens. So you need to keep the pigtail here.
No, we can remove it.
Yeah, it is like initially for a few days so that the inner whatever bleeding or whatever sludges that clears out. And this stent takes it. Stent doesn't expand immediately. It takes time to expand. So once the stent expands, you remove the pigtail here. That is up to 14 hours. Okay, excellent. So can you just tell me the two routes of doing PTVD?
So we can either do a right-sided approach or the left-sided approach.
This is not clear. Is it audible?
Okay. So we can either do a right-sided approach or the left-sided approach. Right-sided approach, we usually do it in the 9th to 11th intercostal space in the right mid-axillary region. So
you tell the benefits of what is the right and left system access. So what is the benefit of doing a right-sided PTVD?
Right side, patient compliance with the catheter is better, and lesser exposure to radiation for the performing intervention radiologist.
And what is the difficulty with that? It is technically difficult. So what is the benefit of performing a left-sided drainage?
It's technically easier to get access into the biliary ducts.
The patient discomfort is more. Okay, fine. Can you go on to the next case first? That's the next case.
So next case is that of a 45-year-old female with history of BTB. She has taken ATT and now she has come with hemoptysis for 3 days of 100 to 200 ml. There is a sudden drop in HV from 8 to 5. Consequently, a chest X-ray and a CT angiogram was done.
Okay. So history of pulmonary tuberculosis. Patient has taken ATT and has hemoptysis. What X-ray findings are you going to expect in this case?
First,
can you go to the X-ray and what are the? Sorry, we just have this scanogram here. Can you interpret this scanogram?
So the scanogram shows a inhomogeneous opacity in the right upper zone. Apical segment appears to be like that of a cavity with some bronchiectatic changes.
So there is one thing that has also happened. What is that? What do you observe that the trachea is pulled to one side? What that means there is a volume loss and cicatrization. So fine. So there is a history of the patient comes to ER with hemoptysis and you are the attending interventionist and they give you a call that patient is. What is the next step that you would take?
I would like to perform a CT angiogram.
Yes. So can you just briefly explain what is the CT angiogram protocol followed in your hospital for patient of bleeding? For hemoptysis?
For hemoptysis, we usually follow 3 phases and an additional 4th if necessary. For the first phase, will that be of that of a pulmonary arterial phase. Second, will that be a venous phase? Aorta. Yes. Third phase, will that be of a delay? And the 4th one, we may take another delay to demonstrate active extracondylar resection.
So what is the first phase mainly meant for? Visualizing?
The pulmonary arteries.
Pulmonary circulation involvement in cases of tuberculosis. So that will have another case, we'll just see. So next stage is the aortic phase where you see for any collaterals. Can you show the next image first? So what is this phase that you are seeing in?
So this is the aortic phase and we have performed phase 2. Yes. So this is a MIP image.
Can you identify the mark structure over there?
So that is arising from the descending thoracic aorta. So that is the bronchial artery.
At what level is it?
It is at the level of D5 to D6.
Yes, D5, D6 level, 2 arteries are. So, fine. So, you identify those as bronchial arteries. They are dilated. Okay. So, now the attending, the ER team or the emergency team asks you to go for bronchial artery embolization. How will you proceed and what are the things that you will see in this case to say yes for taking this patient up for bronchial artery embolization?
First, we'll look at the general patient parameters, bleeding parameters and all that. Once that is clear, we will be looking at the previewing the images. We will first try and identify the bronchial artery, see if they're hypertrophy.
Yeah, what is the size criteria?
4
2
2
Anything more than 2 mm is an embolizable vessel.
Apart from bronchial arteries, we may have other non-bronchial systemic vessels which may also be contributing to this patient's hemoptysis.
This picture?
So in this patient, we can see that a vessel is coming from the neck region and to be around the cavity. So this is likely coming from the cervical trunk, which is a branch of the second part of the vertebral arteries.
Subclavian
That
artery.
is subclavian.
Yeah, very good. So now that you have agreed to take this patient up for bronchial artery embolization, fine. So there is a cutoff criteria to take a patient up for bronchial artery embolization. What is that? Say clinically you see the patient and ask for some specific history where you take this patient up for bronchial artery embolization.
Usually, patients must have massive hemoptysis to be the main indication for us to intervene in an emergency basis.
Define massive hemoptysis.
That will be more than 300 ml in 1 day.
Yes, in 24 hours. That is the criteria for bronchial artery embolism. Can you go to the fluoro images, please? What is artery? What artery is booked here?
So this will be the here in the descending thoracic aorta, and we have hooked on to the right intercostal arteries.
No, it's a bronchial artery. So what are the types of say how many types of bronchial artery anatomies do you know of?
So there is Caldwell classification of bronchial arteries. So there are 4 types.
Yes.
The most common type will that be of single right and 2 left.
Exactly. So what is the percentage of patients that will have this type of anatomy?
Approximately 40%.
Excellent, excellent. So now you have hooked the bronchial artery. You start embolizing. What is the embolizing agent that is used?
So here we will be using PVA particles along with
only PVA particles. Only PVA particles. PVA particles are temporary or permanent agents? They are permanent agents of embolization. So can you just briefly tell me what is the embolization agents that you know?
So we have PV particles. We have the
first classify. Classify is permanent and
temporary.
So permanent are PVA coils, but temporary agent would be a gel. Okay, fine. Right. So in this case, you embolize the bronchial artery. So now what is the next step that you would do?
Look for any other non-bronchial systemic collaterals that may be supplying.
Yeah. So this is it. The post-cervical trunk which you got. So this is non-bronchial systemic collateral. So we have embolized this patient. Okay, fine. So there is one more thing extra that you have to rule out in this patient. See, you have embolized bronchial arteries now. We have controlled all the systemic and bronchial collaterals. There is one more etiology of bleed in this patient, and what is it? That you need to identify in the CT itself and go and block it. What is it?
Though bronchial arteries are the ones mainly involved in the case of TB, we must also be aware of a possibility of a pulmonary pathology.
And what is it called?
That will be called pulmonary artery pseudoaneurysm, and specifically in cases of TB, we will call it as Rasmussen aneurysm.
Beautiful. That's the Rasmussen aneurysm. So you always keep in mind to look for a pulmonary artery pseudoaneurysm in a patient who is having hemoptysis. In a case of tuberculosis. Excellent. So we have covered basics of a fairly simple embolization procedure which is performed every day. That is bronchial artery embolization. Its imaging and how the embolization is performed. This what our Shreyas has answered is basically what is there in bronchial artery. I think much is there to discuss in that, but this is to show what how a discussion can go from a case of TB onto bronchial artery embolization. Can we go to a companion case? Next case, can you read the history?
So this was another case who came with high-grade fever and productive cough. Hemoptysis, massive hemoptysis was there. Consequently, a CT angio was done.
Yes.
So the X-ray shows a big cavitatory lesion in the right mid and lower zone, and on the CT angio image, we can see a irregular and dilated segmental pulmonary artery branch.
Yeah. What is there next to it? Behind it? What you are seeing?
A lot of bronchitic changes.
Yeah, this cavitatory change. So this, what is the mechanism of bleed in these patients in case of a bronchial artery or a Rasmussen aneurysm? What is the mechanism of hemoptysis?
So usually the inflammatory change erodes the walls of these particular vessels, thereby causing aneurysmal changes.
Yeah, they bleed into the bronchiectatic cavities or the lung cavities there, and they cause massive hemoptysis. So how will you treat this patient? What is the best modality of treatment for these patients?
Best modality will always be lobectomy.
Yeah, exactly. It's lobectomy. Okay. So always is to take out the disease lung with the course of antibiotic. And unfortunately, this patient was not fit for the lobectomy. So what would you do next?
We would go and embolize this particular
so endovascular treatment is one of the options. So how do you treat this patient? So I'll not go too many details. Can you identify what has been done for this patient here? So this is the aneurysmal change we have seen the pulmonary artery. What has been done for this patient?
Second image, we have performed a coil embolization of the aneurysm.
Yes, we have performed a coil embolization of the diseased aneurysmal artery. So okay, so we have embolized the artery so that further bleeding doesn't happen in the lung. Of course, until the disease process is controlled, the bleeding is keep on happening. We have just temporarily controlled the patient's bleeding. Okay, so go on to the next case.
So this was a case of a 24-year-old male. He was a known case of polycythemia. He presented with breathing difficulty. Chest X-ray and a CTPA was performed.
Yes. Can you read the chest X-ray?
So this chest X-ray, there is a lobulated inhomogeneous opacity occupying the right lower zone. As you can see, there are two linear opacities which are coursing from the lesion towards the hilum.
No, from the hilum towards the periphery.
From the hilum towards the periphery.
No? Yeah. So you are also seeing something else in this chest X-ray in the lower zone on the right side. What is it? Can you be clear on that part? It's a bunch of opacities you are seeing there, which is silhouetting the downtown. Okay. So we will not focus much. Can you go on to the CT image? There's a peculiar disease. So what do you see in this HRCT X-ray? Shreyas?
So you are seeing multiple opacities occupying the right lung with a few coursing vessels arising from the hilum and moving towards the periphery.
Can you go to the CT image now? Yeah. So what do you see here?
So this is the image. So we can see that there is two vascular structures which are coursing. So one will that be of that of a pulmonary artery, following which there is.
How do you confirm that it's pulmonary artery or a pulmonary vein? Excellent. Okay, so you see the origin of the upper vessel from the pulmonary artery, and it is the lower one is draining into the. Can you just show mark me show the pulmonary artery branch there?
So this is the pulmonary artery. The lower branch, that is the pulmonary vein, is draining into the
left side. So what do you think about this? What is this diagnosis?
So this will be a pulmonary vascular.
No, it's pulmonary
AVM.
Arteriovenous malformation. They say that pulmonary arteriovenous malformation is a misnomer. Why is it a misnomer?
There is no identifiable nidus.
Yeah, so there is no nidus in this case. It's just a direct AV fistula. So an AVM generally has a nidus in it. So there is a direct AV arteriovenous fistula. So what are the other areas where it is a misnomer, where they call it as an AVM, and it is not actually an AVM and it's a fistula? Yeah, it's uterine. Uterine AVM is not a uterine AVM per se, it's an arteriovenous fistula. Okay, perfect. Can you go on to the next BRT image? So you can see beautifully here.
So here
can you identify the structures here?
See the branch arising.
This is the right atrium.
Right atrium.
Right ventricle.
Right ventricle.
RVT.
that is the pulmonary artery dividing into the right and the left branches.
Yes.
So from the right branch, we are seeing the vessel that is leading to this grouped and it is being drained by the pulmonary vein into the left atrium.
So now these patients, how do you think these patients will present? Do they present to you with hemoptysis, or what will be the presentation of these patients?
Usually they will come with breathing difficulty.
Sometimes. So these patients generally are normal most of the times. They might have clubbing, or they might have actually hypertension or saturation drop. Actually, there will be low SpO2, which is undiagnosed. So most of the time they'll be generally very normal. So then routine examination will show that patient has cyanosis and patient might have drop in SpO2, low SpO2. So when they evaluate, they actually see all these things. So also some patients can develop a paradoxical embolization, strokes and all. Okay. And there is one more very important thing. When you see a CT like this, there are cases where people have done a blunder actually. What is the one thing that you should keep in mind and never do?
This is not a lesion. We should not biopsy this lesion.
Exactly.
We should always look at the images in contrast images of this lesion.
Yes.
Should never attempt biopsy just looking at the plain CT.
Because I had a patient who I had seen who was suggested a biopsy. Fortunately, he didn't get it done and came to us for a embolus. So can you go on to the next image? What can you identify what has been done for this patient?
So,
can you read this angiogram picture?
So first image is that of a pulmonary arterial angiogram, which is depicting this bunch of serpiginous vessels, and it is rapidly draining via the pulmonary vein into the left atrium.
So where do you think the access into the pulmonary artery is obtained from?
It is the femoral venous axis.
Yes.
We will be routing into the pulmonary artery by entering the right heart.
Yes. So we have accessed the pulmonary artery, femoral vein, right heart, and entered into the pulmonary artery and lodged the catheter in one of the pulmonary arteries. So what has been performed here?
So the main vessel has been embolized using a vascular plug, whereas the smaller subfeeder vessels are embolized using coils.
Yeah. So Shreyas was there for this case. He knows about this case. So just for the PG sake, this is a Amblatzer vascular plug. because generally coils do not stay in this vessel because of the high flow and cost issues also. These generally vascular plugs are not as expensive as those coils. We need a lot of coils to embolize this huge vessel. So what we generally do is we'll plug this vessel, and it is made out of metal actually. So it will immediately thrombose. Thrombus will form over the top of it. So antegrade blood flow stops, and whichever the smaller branches where you can't put a plug, we generally coil it with plugs. So you can compare the two images where you can see the whole AVM is taken off. And it doesn't matter, we are not going to kill the lung and all, there won't be any infection because this lung is somehow not perfused properly because of the fistula and shunting. So it doesn't matter if you block it also. Fine, Shreyas. Can we go to the next case fast? We have now, yeah.
So this is a 80-year-old male. Is a known case of rectosigmoid growth, probably CA, presented with bleeding per rectum, and there was a drop of HP2 about 4 grams.
Yeah.
CT abdominal angiogram was performed.
Yeah, so bleeding patient comes to you. So what is the very first question that you ask the patient?
So first,
say GIB. So what is the first question you ask for a patient who is having bleeding per rectum as an intervention? So what is the first question you ask? What is the type of bleeding?
yes. What is the type of bleeding?
Frank blood or clots? Or it was melena or hematopoiesia? So can you just tell me a few causes of lower GI bleed?
Lower GI bleed, most common would be malignancy, angiodysplasia.
Most common cause in an elderly male.
Diverticulitis.
This is diverticulitis. Second one?
Malignancy,
Angiodysplasia, infections, then comes cancer. Okay, so how do you differentiate an upper GI from lower GI bleed?
So the anatomical landmark is that of the ligament of Treats.
Yes, ligament of Treats divides the upper GI from the lower GI. Fine. So can you just tell me the gut arteries?
So the foregut artery mainly is the celiac trunk. The midgut is the superior mesenteric artery, and the hindgut is the inferior mesenteric artery.
Excellent. So inferior mesenteric artery is the hindgut artery. So the hindgut mainly is the where the hindgut is splenic flexure. What is it called? So splenic flexure. The watershed zone of abdomen, or there is another name for that. Sudex. Okay. So that is the descending colon, sigmoid, and the rectum. So now that the patient has, what do you see in the CT image here?
So first image is that of the plane image.
Yes.
So second image, as we are seeing here, there is some area of
face of the image.
Face is that of arterial face, and we are seeing some area of active extravasation and some contrast puddling within the rectum.
So what artery would you suspect bleeding in this patient?
So at the level of the rectum, so most commonly I would be thinking of the superior rectum.
Superior rectum is the branch of
inferior mesenteric artery.
Excellent. So it is the hindgut bleed. So it is mostly a inferior mesenteric artery. Can you go on to the next image? What is this image?
So this is the coronal MIP image. So we are mainly concentrating on the inferior mesenteric artery. So the first branch will be the left colic branch, following which we have the sigmoidal branches, and our artery of interest is that of the superior rectal artery, distal to which we are seeing some area of contrast puddling.
Okay, so now that you have located the bleed, which is the best modality of imaging to look for the site of bleed? You know of? What is the best modality to detect the site of bleed?
So the best modality would be technician 99 RBC scan.
And what is the ml of blood that it can do? How much sensitive is it?
It can detect as small as 0.1 to 0.3.
Excellent. So it as low as 0.1 to 0.3 ml of blood is what technicians can detect. What is the next imaging modality that can detect bleeding?
Next could be endoscopy.
It is CT. So 0.3 to 0.5. So how much is the sensitivity of fluoroscopy? Fluoroscopy can detect up to 0.5 to 1 ml of blood. Okay. So fluoroscopy is the least sensitive of them all. Why? Why can I ask?
Bubble gases will be obscuring the
and movement of the patient generally obscures the DSA picture. So most of the times obtaining or seeing a fluoroscopic bleed on a fluoroscopy is very difficult. Excellent. So how will you treat this patient now? Can you just tell me the route of the catheter where we have taken the access into?
So we have obtained the left femoral arterial access.
Yes.
So we have used a reverse curved catheter. Here in this case, it's a SIM1 catheter.
Okay.
And we have performed an angiogram. As you can see, the inferior mesenteric artery
branch
that
superior
is the superior rectal artery is delineated well on the second image.
What is wrong with that superior rectal artery?
There is evidence of active flush.
No, there's no active flush. We are not seeing generally in gut bleeds, the artery goes in for spasm after bleed. The artery is tortuous and irregular, which is very, very common in a case of rectal malignancy. Even though we do not know, we are not seeing a puddle or a flush, we'll still go and block the artery. What have you done here?
So here we have done a coil embolization of this involved artery.
Yes. So we are sure that the bleed is from the superior rectal artery. So we have gone and blocked the artery and this patient improved. Okay. So any GI bleed, first is to study the CT image properly. Can you just tell me a few causes of upper GI bleed?
Upper GI bleed usually will be peptic or duodenal ulcer. Malignancies. But from the duodenal lesion and vascular ectasias.
Yeah, excellent. So can we go on to the next case?
The next case is that of a 64-year-old male. He is a known case of SPHAG related liver disease.
Yes.
He is on drug chemotherapy and recently has developed pain abdomen. So ultrasound showed a segment 4 lesion and his AFP was about more than 2000.
Okay, stop there. What are the corroborative findings that you look in from this history? So everything is given here. So what picture do you make of in your mind?
Could be a hepatocellular carcinoma because there is a background of SPHAG in this patient.
And what supports that finding?
The lab finding of elevated AFP supports that.
Yeah. So if AFP is elevated with the patient with HBsAg positive disease, liver disease, cirrhotic patient, and a focal lesion in the liver. So the focal lesion in the liver, okay, AFP was not given. What would you think of that lesion as? So now you are clear that it might be an HCC. So what other things will you think of if the AFP was not given in the picture? What other things?
Dysplastic nodule.
Excellent. It's a regenerative nodule or a dysplastic nodule. So what is the best imaging modality to differentiate between a regenerative nodule and a HCC?
MRI.
CT or MRI, both will help you. But MRI, they say with diffusion imaging and all, you can make up T2 and diffusion imaging. They say that you can delineate the lesion better. And also post-TACE, imaging is better with MRI. TACE, of course, yeah. Can you interpret the CT?
So first is that of a non-contrast CT, which is showing a lesion here in the segment 4 of liver, and the second image is that of the
liver behind.
Yeah, the liver appears heterogeneous in echo texture and shows some surface nodularity also.
Yes.
The second image shows the avid enhancement of the lesion in the arterial phase.
Yes.
The third image is that of the coronal section, and that is shown to demonstrate its close proximity with that of the
washout. So okay. So now there is a HCC proven here. So will you go and do any invasive procedure in this to confirm HCC?
Not necessary. CT diagnosis of HCC is adequate.
Which are the guidelines which say so?
European
guidelines have come out which say that there is no need for a invasive FNAC or biopsy to prove a HCC. But of course, we are doing for few cases who are undergoing oncotherapy. So okay, sir, fine. So they now have a single solitary lesion in whole of the liver. There is no metastasis. We have confirmed. Do you know any therapeutic procedure that can be done to cure this lesion? What would be the best treatment modality for this patient?
Best would be surgical. Remove the lesion itself.
So what is the problem in doing surgery in such patients? Surgery is problematic in this patient because of the portal hypertension and lot of the abdominal wall collaterals, which makes it very risky to get inside the abdomen and resect it. So what is the other safe?
Endovascular management can be done. That
before endovascular. What is the other best modality to cure this type of lesions?
Ablation can be tried.
Yeah, percutaneous ablation with microwave or RFA. Why do you think RF is dangerous in this patient?
As you can see in the third image, the lesion is quite close to the heart border. Therefore, ablation would be risky and
so it is possible to do, but then it would still be very risky. So what is the other treatment modality that you know
of? We have the option of TACE.
What is TACE? Can you abbreviate TACE?
Transarterial chemoembolization.
The transarterial chemoembolization is infusion of drug basically into the artery within the lesion, so that the systemic complications are reduced. Okay, so what is the artery cannulated here? Can you just name the catheter here? You just told now.
The Simon catheter again. Yeah, so we have cannulated the common hepatic artery.
Yeah, exactly. So, and can you just point the common hepatic artery to me?
So this is the common hepatic artery. So we have a branch here that is the gastroduodenal artery.
Excellent.
Following which we have the proper hepatic artery.
Excellent. So what do you see other than that? There is something else also see. What do you see there?
As you can see that there is a hypervascularity surrounding the our area of interest, that is around the tumor. That vascularity is arising from the left hepatic artery.
So there is one very peculiar thing you are seeing in this image, Shreyas. Can you just make out? Can you just tell me what is not there in this image? Do you see the right hepatic artery? You're not seeing the left hepatic artery. So what is the variation, arterial variation that you would expect in this patient? Where would the left hepatic artery arise from?
Can arise from the left gastric artery.
Yeah, exactly. So segment 4 artery is coming over here. Sometimes in some patients, left gastric artery can give a left hepatic artery. So that is a variation which is seen in this patient. So can you just compare these two images? What is happening in the second image? Can you just identify the catheters that are used over here? What is the? Can you name those catheters?
So here we have used a microcatheter to extend deeper into the arterial system.
Excellent. Yes. So that you do not infuse the whole drug into the entire unit, so that you focus the drug exactly on that point of interest. Okay. So what is this puddling and density over because of?
The chemotherapy agent that we have and the lipidol.
It's because of the lipidol. Lipidol is the carrying agent or the viscous agent, the pacifying agent, which helps in what you call it adheres to the drug and takes it into the tumor. So what is the most common drug that is used for taste?
We can use epirubicin.
Yeah, no, first is doxorubicin. Doxorubicin and next one is epirubicin. What is the complication of injecting doxorubicin into the body?
Can have a cardiac toxicity.
Cardiac toxicity, excellent. So doxorubicin is known for its cardiac toxicity, so epirubicin was introduced, and this chemotherapy at this local spot generally prevents all its systemic complications of cardiac complications at a later time. Excellent. So now we have seen a case of transarterial chemoembolization. So where do you know of any other condition that can be treated with transarterial chemoembolization? That is, liver hemangioma can be treated with bleomycin transarterial chemoembolization, and also colorectal metastasis with irinotecan test. Okay. So what is TARE?
There is transarterial radioembolization.
Yes, radioembolization for inoperable malignancies which have invaded into the portal of the hepatic. So what do you inject in TARE?
We use yttrium spheres.
Yeah, yttrium Y90 spheres. And what do they emit? The beta. So they emit beta radiation. So they are beta emitters. What are the other drugs do you know? Do you know of any other drugs that can be used there? Rhenium and iron. Okay. We'll not go too much into this. Okay, can you move to the next case, please?
So this is a 31-year-old female. She came with headache and signs of amenorrhea. GCS is 15 and 50. CT angiogram was done.
Yeah.
In view of headache.
Thunderclap headache, young patient, GCS is maintained. Headache, what do you think of?
Thunderclap headache, I would think of subarachnoid hemorrhage.
Yeah, SH. So first thing what you do is CT. Plain. Can you interpret the plain CT for me?
So as you can see that there is hemorrhage in the bifrontal region as well as the interhemispheric fissure, also associated cerebral edema in the involved area.
Yes. So interhemispheric fissure CT. Interhemispheric fissure has a bleed inside. Okay. What other thing do you see for whenever you are seeing a patient of SH?
We must always find out the cause of the SH.
What is it in plain CT only? What do you think? What do you see in the image? IVH. Rule out an IVH. And what is the CT grading criteria for Fisher's grading?
Fisher's grading.
Okay, Fisher's grading includes less than 1 mm, more than 1 mm with IVH or without IVH. Okay. So now a patient has come to you. You are the intervention radiologist who has given a call to look at this patient. Now you are seeing the interhemispheric bleed with some bleed in the sylvian fissure. So what is the most probable site of bleed you would suspect in this patient?
So the site of the SH usually gives us the clue as to what artery can be involved. So here it is the interhemispheric fissure. So I would think of a ACOM to be the involved artery here.
Yeah. So ACOM aneurysms or dark aneurysms, then distal AC aneurysms most commonly bleed in this interhemispheric fissure. So okay, now a patient comes with SH and also has brain infarct. So what do you think about in that patient? So see the patient GCS was 15 by 50 and patient is deteriorating. When you do an MR or a CT, you see a lot of infarcts in the brain. So what do you think?
What could have happened is that the vessels could have gone into vasospasm because of the SH, thereby causing infarcts.
So SH-induced vasospasm is one of the prognosticators in the case of SH, and it can be detrimental if the patient goes in for cerebral vasospasm. Fine. Now you know where exactly you're looking for. Can you go into the CT angio image? These images are not that of great quality. Even then, can you interpret what you see here?
So here you are seeing a saccular outpouching arising in the area of the ICOM that is better delineated here on the 3D reconstructed image.
Yeah. So this is an ACOM aneurysm. So most of the aneurysms say anterior circulation, posterior circulation. Can you tell me what is the percentage of aneurysms, which is the highest, which is the area where the aneurysms are located very commonly intracranially?
It will be the anterior circulation more than the posterior circulation.
Yeah,
Most commonly the ACOM.
How much? 90%. Posterior fossa, posterior circulation, 10% of the aneurysms are in posterior circulation. Okay. And what is the most common area of involvement in posterior circulation?
Basilar.
Yeah, basilar top. So basilar top is generally the most common site of involvement in the case of say intracranial. Fine. So what is the clinical grading that you know of for prognosticating a patient with SA?
We use the S and Hunt scale for
S and Hunt scale is most of the common used for prognosticating these patients. But what is the most common clinical criteria that determines the outcomes in these patients?
whether the aneurysm is ruptured.
No, it's GCS. It's only and only GCS. How is the GCS of the patient? GCS is very poor. Say patient is moribund and comatose. The prognosis is very poor. Okay, fine. So now that we have seen the morphology of aneurysm, what would you do next? Now, this is they can do clipping on a CT angio. What is the next step that you would do as an interventionist?
We can do endovascular.
No, to confirm this aneurysm,
I would like to do digital subtraction angiography of the cellular circulation. Usually a 4-vessel angiogram.
Yes, 4-vessel. Can you interpret this angiogram?
So the first is that of a right cerebral angiogram in the AP view. The second one is that of in the lateral view. As you can see, there is a focal outpouching in the area of the ACOM, which is delineated in both the views.
So that is a
ACOM aneurysm that we are looking at.
What is one? What are the things that will tell you that this is a very high risk aneurysm which has a rupture?
So we can see that the surrounding vessels have gone into base.
What is the criteria which tells you
The size of the aneurysm is
more than 5 mm, a daughter sac and a teat tells you that this is an aneurysm which has a rupture. There might be multiple aneurysms in the brain. How do you tell that this is a rupture? It is the teat and the daughter sac. Okay, that is one thing very nefarious in this image. What you see that very bad thing in this patient which has happened.
vasospasm.
Yeah, patient's arteries are in vasospasm, severe vasospasm is there. So this also determines the patient GCA. The patient's GCS was actually dropping. So when we took up the patient, we had to infuse the patient with milrinone and nimodipine. Okay, so this is cerebral vasospasm in a case of ruptured ACOM aneurysm. Fine. So what is the one autosomal dominant disease that is generally associated with the berry aneurysm, or say that disease patients have this berry aneurysm?
ADPKD is usually associated with berry aneurysm.
Yes, exactly. So what is angionegative SH? Angionegative SH is when you don't find any aneurysms. There are multiple causes for it. What will be one cause of SH where you might not find aneurysm? Can you tell a very common cause? Trauma, of course, trauma history will be there. Without any history, thunderclap, venous. CVT with venous bleed can have SH. Okay, so look for that also. And what is pseudo SH?
On imaging, you can have
the edema. Brain is in severe edema. The blood vessels in the dural sinuses look very dead. So that will look like SH. Okay, that is pseudo SH. So treatment options available for this?
So we will likely coil this.
Two options.
Surgical as well as endovascular.
Endovascular. So what would you do for this patient? Coiling. If endovascular is the treatment of choice, coiling, and also relieve the vasospasm. Okay, with the vasodilatation. We will not go too much deeper into this discussion. Okay, this is what is this image called?
3D angiogram.
3D volume render image with surface shading. Okay, 3D surface volume rendered image with surface shading. So how does this help you? Taking this image will help you in the management of the patient.
We can plan the intervention that
it gives you the exact size and morphology of the image. Can you see these irregularities in these images over here? That means that these are daughter sacs, and maybe there are teats also in the aneurysm which has a rupture. There's a daughter sac here also, so it's a ruptured image. So this image especially helps you in planning the aneurysm treatment and also gives you a morphology, and also we can see if there are any tiny blister aneurysms and all in the other areas. And also, what are the types of aneurysm you know of? Can you just past types of aneurysms that you see in intracranial vessels, which can be
fusiform, saccular.
Yeah, saccular, fusiform, blood blister aneurysm. So where do you see fusiform aneurysm very commonly? Posterior fossa, the vertebral artery segment. Okay. So this is sacculars are very common in the anterior circulation. It's not hard and fast one. It can happen here also, but fusiform aneurysms are very common in posterior circulation. Fine. We have coiled this patient. Can you see the? Yeah, we have coiled this patient. I'm not put the coiled images and all because it's it becomes too extensive. Okay. So this is the post of CT. Now, what is the best thing that has happened to the patient? Do you see any good predictor post coiling?
What does SH is relieved and the cerebral edema which we had seen in the preoperative efforts.
One more thing. We are seeing vasospasms. There are no new infarcts in the brain. So that means the patient has come out of the SH phase and the nimodipine has worked and the cerebral vasospasm is relieved. That means the patient is now fit for discharge. This was the discharge CT. Okay, the patient was fit for discharge and she was discharged. And this is the coil mass which you are seeing here. Can you go to the next case, please? Yeah.
So this is a 53-year-old male, came with acute onset left-sided weakness. He's a chronic smoker and is COVID positive. And
NHS score is 10. So can you interpret this CT, please? MRI, please.
So this is a diffusion weighted sequence which is showing areas of diffusion restriction in the right MCA territory.
And what is the shape of this diffusion restricted areas? They're triangular, right? Peripheral. Yeah. So what is the difference between why did I say you this is a and what would be the etiology in this patient for stroke? So this patient presented with weakness, it's a stroke. So what do you think is the etiology in this patient?
Embolic could be.
Why do you say it's embolic?
Multifocal peripheral small infarcts.
Yeah, it's triangular base towards the white matter, and also it is involving the MCA territory. It can generally embolic stroke generally involves all the territories. So what is the hemodynamic stroke? Hemodynamic stroke is generally seen in the watershed areas. So what are the watershed areas you know of in the brain?
We have the ACA, MCA, and the MCA.
Posterior circulation, anterior circulation. So generally these infarcts are noted in those watershed areas. So you have to suspect a hemodynamic stroke. Can you tell me some causes of embolic stroke?
Either it could be cardiogenic, where there is embolic phenomenon occurring because of a cardiac cause, or secondly it could be because of a plaque within the carotids, which are slowly rupturing and forming embolic material.
What do you call that condition as? Artery to artery embolization. And what can you tell me few causes of hemodynamic stroke? Hemodynamic stroke is a reduction in the cerebral blood. Carotid stenosis, hypotension, okay, and intracranial atherosclerotic disease causing narrowing of the vessel. Okay, can you go to the next slide, please? Okay, so can you interpret this MR angiogram?
So this is the MR angiogram reformat, which is showing absent flow signals in the right ICA.
But you do see the common carotid.
Common carotid, yes.
So, okay, fine. So, what are the first diagnoses that would come into your mind when you see a picture like this?
So, I would think of an ICA thrombus.
ICA thrombus, and one more thing, very important condition. ICA dissections. So, ICA dissections and ICA thrombus, acute thrombus or a floating thrombus, sometimes can lead on to picture like this. Of course, there will be dissection will show bright signal and all in other imaging sequences, and in this patient also. Okay, now you're not seeing the IC, and the patient has acute stroke and has come in with an NHS, so you intervene as an intervention radiologist. Can you just go? We'll just wrap it up just for curiosity's sake for you guys. So what have we done here? Stroke is on the right side.
We have performed a left-sided cerebral angiogram.
Yeah. Why?
So we would want to look for collateral status. Exactly. See for pile collateral status.
Yeah. So before going and intervening on the affected side, we'll just go and confirm that why is the you see the IC is totally occluded till the infarcts are small in that area, right? So what is the meaning of that? That means the brain has very good collateral status. Can you name me one other imaging modality that can confirm this collateral status? Triple phase CT of the brain. Triple phase CT of the brain has 3 phases of angiogram, which confirms in what phase the imaging collaterals are seen. So based on that, we can tell whether the patient needs a thrombectomy or doesn't need a thrombectomy. How long can we delay the thrombectomy? Fine. We'll not go into the details of that imaging modality. So we have done the same thing here. We are confirmed. Can you go to the next image also? What is this Angiogram?
This way performed the left vertebral artery angiogram to look for the status of the posterior circulation and any collaterals.
Do you see collaterals in this image?
Yes.
Where do you see those collaterals?
Supplying the MCA area around this area.
Exactly. So it's retrogradely filling the MCS by territory also. But this is not enough. You see the perfusion image of the brain. Where do you see a lot of perfusion defects? So can you just go to the next image? Now see, this is, you are seeing a faint MRI signal in the top, right?
Yes.
So that is same you are seeing in angiogram, and it is stopping exactly at this level, at the what is the cavernous level. So why do you think this has happened?
Because there is thrombosis distally, and that is there is a status of the contrast that we have.
No, there is an occlusion. There's a tight stenosis there, or a ICAD which is sitting there, or a atherosclerotic disease which is causing occlusion, and there's passive collapse of the IC. So there, because there's no antegrade flow, the blood is stasis in that, stagnant in that region. So it is visualize it like this. But in a case of dissection, you would not see this. You see a flame-shaped image with no antegrade perfusion at all. Okay, so we have done a thrombectomy for this patient. Now you can see it clearly, right? There is a plaque over here sitting here, right? Yes. Okay, that would have been above, or there is a plaque above also. There is an area of stenosis narrowing over here, and the blood is. So can you just see the next image also? What have we done for this patient? We have done a stroke thrombectomy, mechanical thrombectomy for this patient. Can you see the irregular MC over here? This the IC over here. So maybe the blood was coming and stopping over here in this cavernous segment, right, in the ophthalmic segment and all. So there possibly was the plaque over there which was causing stenosis of the vessel and poor distal flow was there. Now that we have opened the vessel, now you can see the antegrade flow. So before taking up for stroke thrombectomy, what is one scoring that would you do for this patient?
Aspects.
Yeah, what is aspect score?
Alberta stroke.
Yeah. So how do you divide that? How many territories are there?
So we can do for anterior as well as for posterior circulation.
Just tell me anterior, posterior.
Anterior we have 10 areas.
10, look for. 10 is fine. 10 is fine. So 10 is there. What is the minimum score that you need for to take the patient up for thrombectomy? 6. Yeah, 6 or anything less than 6. The prognosis is not that great. And say how till what time can you do mechanical thrombectomy?
For anterior circulation, we can take about 6 to 8 hours. While for posterior, 12 to 24 hours.
Yeah. What if the patient comes after 6 hours of quick test? Now the window period. What will you do? To perform a perfusion imaging, CT perfusion imaging to look for the
penumbra status.
Yeah, core and the penumbra. So if the core is matching with the penumbra, then there is no meaning in saving that thing. And if the core is small and the penumbra is big, that is the reversible, salvageable blood. You go and enter. Fine. So this is a little bit about stroke thrombectomy. Can you go to the next slide? Can you just wrap it up with instruments in IR? Can you just identify these two instruments there?
So one is the first image is that of the puncture needle, with the cannula, and the second image is that of the access sheath,
vascular access sheath
with the dilator as well as the guide wire and the introducer.
Yeah. So the sheath, generally, what are the types of needle do you know? Do you know of any needles other than this? So there are two types of needle. One is the direct puncture needle and one is the Jellicoe type of where you do double wall puncture and withdraw the needle. This is a single puncture needle which we are very routinely using. So what is the technique again used for getting a vascular access? What do you call this technique? Cell division. But we are using modified cell division technique to obtain a vascular access. Fine. So can you explain me the parts of the sheath there?
So we have the sheath with the attached side port, and then we have the dilator. Following which we have the guide wire along with that of the introducer.
Yeah. So you puncture the artery with this needle, insert this guide wire. And why is this dilator? What is the purpose of dilator? Purpose of dilator is to make a space for the sheath to go inside. Okay. Sheath is a little bit floppier so that it will get kinked if you pass it without the dilator. So dilator spreads the soft tissue and makes a space for this to get inside. Okay. So this is a vascular access sheath. And how do you see there are various sizes of sheath? How do you identify the size of the sheath that you want? Based on the color coding. You can see this green color over here. Gray color is 5, 7 is orange. So based on that, you have color coding system also. Okay, that is how you identify the vascular sheath. And what is one peculiar thing about vascular sheath? Why do you put a vascular sheath in the first place? You can directly pass over the wire, catheter. It has a one-way access one. You can put a catheter inside, but the blood wouldn't come out. Okay, and what is the drug you use to keep the sheath patent?
We will use heparin.
Yeah, heparin. Heparin is infused into the body based on the body weight of the patient to keep this patient to achieve a anticoagulation state so that the sheath stays patent. Okay. Can you identify this instrument?
This is a guide wire.
Yeah. What type of guide wire is this?
This is an angle guide wire, J-tip guide wire.
And what is the specialty of this guide wire?
It is coated with Teflon, so therefore it is hydrophilic.
Yeah, so it's hydrophilic. Why do you need hydrophilicity when you get inside the blood vessels?
Easy passage of the guide
Smooth
wire.
passage. So it gets activated. Hydrophilic coating generally slides inside the arteries very smoothly, so that there's no friction between the blood vessels and the endothelium is not damaged. And what is the other type of guide wire you know of? Companion guide wire to this would be straight tip guide. So this is an angle, there is a straight tip. So what is the difference between this and this guide wire and this guide wire? This guide wire is a steel guide wire. This guide wire is Teflon guide wire. So it has hydrophilic coating on this one. So PTFE coating will be there, so it makes it easy passage into smaller vessels. So okay, so identify what is the structure.
These are catheters.
Yeah, these are vascular catheters, angiographic catheters. Can you name a few angiographic catheters that you have come across?
Like if we have seen a Siemens 1 catheter. There is a
basic most one that you use.
Vertebral catheter.
Yeah, vertebral or
Cobra.
Yeah, Cobra catheter.
And Judkins left.
Yeah, those are cardiology specialty catheters. Okay, so these are angiographic catheters to cannulate the vessel and inject contrast inside the vessel to look specifically what is the disease status. Okay, so how do you take this guide catheter in the body?
We will have to first introduce the guide wire over which we'll have to pass
through the pass the guide catheter and the guide wire combination. Never go without, because this can cause dissection of the intima. Okay, so it is the guide catheter. So we know this is Omnipec, it is written over there. So do you know? So say Omnipec has 350 mg of iodine in it. So what is the patient of this iodine salt? Do you know any other contrast agent which is safer to use in patients with renal detachment?
We can use iodine which is Visipic.
Visipic, iodine.
Trade name.
Yeah.
Visipic.
Yeah. So we use renal sedation. So say a patient comes with a peripheral arterial disease and you want to do a peripheral angiogram, and patient has deranged renal function. Patient is CKD. What is the one contrast agent that will use for that patient? Do you know of any contrast agent that can be used for such patients?
We can use CO2 angiography.
You use carbon dioxide angiography. What is the main hindrance with the carbon dioxide, using carbon dioxide as an agent? It is a gas, so it displaces the blood. You need special imaging modalities to visualize the displacement of the gas. It is not like it mixes with the blood envelope. It displaces the blood envelope. And where should you not use carbon dioxide as a contrast agent? Never in heart and brain. This can cause air embolism and stroke. Okay, so carbon dioxide requires a special apparatus to introduce and special imaging modality to image it. Okay, and again, vascular complications of contrast agent, all this allergy and all these very known factors will not go. So, what is this issue? What is this? The issue?
This is a stent.
Yeah, vascular stent. And can you tell me a few things about the stents?
So stent is a metal mesh that we placed across
metal tube,
which we place across the site of stenosis or occlusion. They are usually made up of either nitinol or
metals,
stainless steel.
Okay. So what are the two types of stents do you know of? Self-expanding and balloon expanding. Okay, which you place on a balloon and expand the balloon so that it takes the shape. These are preformed shape. You just open it, it takes the shape of the vessel. And how do you determine the size of the vessel, size of the stent you want? You measure the size of the vessel on CT or the fluoroscopic image. Okay, then you decide on the stent. Okay, fine. So what are these two stents?
So the first image is that of the PVA particles, and the second is of the gel foam.
Yeah. So we have already discussed that the PVA particle is a permanent embolic agent, and gel foam is a temporary agent. So what is this 250, 355 written over here?
That is the size of the PVA particle.
Yeah. So these are generally polyvinyl alcohol particles which are pounded and powdered and pass through separate seals which are having these holes of these micrometers. Okay. So what is the size you use in lung bronchoalveolar embolization? Do you know?
250 to 355.
Why do you use 355?
If you use less smaller sizes, then it can go into the pulmonary venous circulation.
So it crosses the capillary circulation in the lung and go on to the pulmonary venous circulation, which can lead on to stroke. So what is this agent you know?
This is first image is that of the glue, and second one is that of the lipidol.
Yeah, what is the relation between the two?
They are used as a mixture for.
This is the emulsion agent. Emulsion you make with glue. This is a permanent embolic agent. You can't put glue directly you have to use the lipidol as a carrying agent always, and it's a permanent embolic. What is this agent?
This is a coil.
Yeah, what is this coil called?
Fibers.
Exactly, it's a fiber coil. What is the coil made of? Platinum. Platinum. So the platinum coil used for permanent embolism. Anywhere. Aneurysms, peripheral bleeding, anywhere. We have used it for rectal embolism. So this is a permanent embolic agent. Okay. So this is a coil. We have crossed 1 hour.
I think that's still okay, Dr. Harshit, because your it was a very, very, very amazing discussion.
Thank you.
First I'll let Dr. Venu sir. Gomati ma'am is also joined.
Yeah. I was listening to, I was seeing all the images, and the student is answering just like as he's an interventional radiologist. He's speaking out so nicely. That's what I was wondering. Very well done.
He's the right guy I've got. He's interested in intervention. So he's the right guy we have got actually.
Yeah.
Student,
I was thinking he was answering so nicely. I was wondering really. He was answering each question you asked.
Yes,
thank you so much. Wonderful session, Dr. Lennon. I was really very happy when you came for our Kerala academics again. Huh? Okay.
Ma'am. Okay.
Yeah.
Ma'am, Venu sir, you want to add something, sir?
No, I think Dr. Harshit, actually, you, I think, showed us all the variety of cases now, the spectrum of all type of cases and also interventions. So very beautifully explained, and also I think it took some nearly 60 plus 30 minutes, but still no, some 11, 12 cases were shown, and the procedure and the equipments. So I think this is good for a theory exam as well as for the practical exam now. Especially for the practical exam, it's good.
This is just an overview of what are the types of questions that can be asked. Because I have given multiple exams before as a PG student trying for intervention. So I know what is the type of questions can be asked. So I just put those small here and there questions.
Okay. And I hope, I think this would be there in the YouTube now. So before the exam, I think you can just have a second look or third look or whatever it is. You can see the video so that it will be useful. It will be highly useful for the exam now. Thank you very much. And Dr. Shreyas, I think you had a tough time because you were the only one candidate here answering all the questions and all, and the examiner was asking questions very fast, and you were answering also very fast, and especially it's very difficult to answer all the time and be vigilant throughout this long period, that is 1.5 hours. So thank you very much. Thank you very much. And you did a great job for Kerala IRIA. Thank you.
Thank you, sir.
Thank you so much, sir. Like all of them mentioned, Dr. Harshit and Dr. Shreyas, it was really a very nice session. Main thing being, like we mentioned earlier, we don't get a lot of exposure with interventional, and the students more so. They don't get a lot of exposure. So even when they come during the exams, they might be still able to hold on to the rest of the systems. But during the interventional radiology cases, they end up fumbling, especially when they are shown with, you may still answer what does the image hold, but when they start asking more about the procedure, they are lost. And you told exactly the kind of questions that would be asked on how they should deal it, how they should approach. So it was very, very, very useful. I was actually learning a lot of points when you were
Yeah.
there.
And actually
it was
showing all the instruments also. That is important for the students.
Definitely. It was a very good session.
Yeah. Sorry for calling Lennon. Actually, it's Harshita, isn't it?
Yes.
I mistook for Lennon. Sorry, Harshita.
Because during the whole discussion, ma'am, actually Harshita has been behind the screen.
Yeah.
He's been hiding in the corner.
No, I saw only half his face. That's right.
His face is not seen.
I want to see his face. I want to show his face. Exactly. I think he's so not tense much.
No, actually, Dr. Shreyas, you handled it really well.
Yeah, very, very, very nicely. I know. Congrats.
So thank you so much once again. And there were, I think, 2 questions. Okay, no, there's just one. Can you suggest a book from where to read and prepare for this question answer pattern preparation?
So, madam, the basic is requisites. The requisite series which is there, it has a part on interventional radiology also. The requisites imaging of MSK, cardiac. There is a book written by Dr. Kaufman also. That actually is basics for his MD students, intervention. It's a small book, tiny book. And one book is there, which is Krishna Kandarpa. It's a handbook of interventional radiology. Beautiful book. It's a tiny hand pocket book, which all PGs should keep and read actually, who are interested.
So I hope
in
that everybody got that answer.
Yes, ma'am. Krishna Kandarpa and Kaufman. These are two excellent books actually.
Do you mind just typing it down as an answer to the question which is already there in the Q&A?
Yes.
That
Yes,
would be
madam.
better, I think. There's an option there. You can answer that.
I'm typing it actually, madam. Krishna
I don't want
Kandarpa.
to type something wrong. That's why.
Krishna Kandarpa's handbook.
Because interventional radiology, everybody finds it difficult. Answering it, knowing the procedure, knowing what is the kind of question that a teacher will want.
It's by Kaufman. If you put Kaufman, it generally comes up actually. So should not be an issue.
Yeah. Okay, yeah. So for those who are interested, this is there in the answered section of the Q&A now. So I'm sure all of you can use this during your preparations, interventional radiology. This was a very good session. And other than just the live session, this gets circulated a lot also. So we are hoping this session is going to be very useful to the rest of the PGs because, like I told, it is a very rarely spoken about topic, but an important part of the exam. So anyways, thanks once again, Dr. Harshit, Dr. Shreyas. Thank you so much. I know you were finding it very difficult to get a PG. And Dr. Shreyas, you filled in the shoes perfectly.
I just caught this guy because he was going around. I just caught it.
And ma'am, you wouldn't believe it. I just told Dr. Harshit, I probably was not very clear about what I told. The next day, he has prepared a 90 slides ka PowerPoint for the talk. And then I'm like, no, I need a PG. And then he changed the whole strategy and he got Shreyas involved. So thank you so much.
Thank you so much. Thank you for being with us.
Yeah.
Thank you.
And thank you so much, Gomiti ma'am, for joining in. Thank you, Venu sir. I know this was a long talk. It was a very interesting talk for all of us. And no, it was very useful. I'm sure all the PGs, there was practically nobody who, I didn't see anybody leave as such. So it was a very interesting and a very useful one. Thank you so much, Venu sir, Gomiti ma'am. Thank you, Ramesh sir. I think he left. Thank you, Riju sir. Thank you, Soumya and team, MedPiper team, for giving us this platform. And thank you all the attendees because you have made the session, you have made the session more, it is more productive because you people are there. So thank you so much for supporting us. And hopefully you will continue doing the same. So with this, ma'am, Gomiti ma'am, Venu sir,
we can wind up.
So thank you, Harshit, once again. Good night. Good night, ma'am.
Good night.
Good night, Soumya.